progress in malaria prevention. There was a time when we had so many cases of malaria reports, but now it's gone down significantly. And to talk about how to totally eradicate malaria, we're joined in the studio this morning by Dr. Kezia Maum, Program Manager, National Malaria, for the good work you're doing in malaria elimination and prevention.
Thank you, thank you.
Is malaria still a problem in Ghana?
It is still a problem because people are still dying from malaria, people are still falling sick from malaria, and we are admitting people for malaria. Yes, we have made a lot of progress, but it is still a problem. In terms of the number of cases that we see at OPD, malaria still contributes to about 20+% of the cases we see on the outpatient.
That's high.
That's still high.
Is this in adults or in children?
So it's both, but relatively we still see malaria affecting children more than in adults. You know, even though we have a bigger population in terms of numbers of the adults, if you look at the proportion of children who get malaria, it's higher in children.
Is it because adults have built some kind of immunity to it, or we are not exposed, as exposed?
So generally, in a country like us, where malaria is endemic, we say endemic because it's everywhere, everybody is at risk. We have some partial, it's not complete. When it's complete, it means you don't get it at all. But we have a bit of partial immunity as we grow and we are exposed to the malaria. And so that may be a reason why, it's not the only reason why the adults are not that affected as compared to the children. And the children's immune system is still being built up. Yes, yes. But interestingly, the picture is beginning to change. So it's not so much in the past. I mean, it was mainly children under 5 being affected. I know we are doing a lot. So in a way, we are protecting the children at their younger age more. We're looking at our data, and in Greater Accra, for instance, you see that we are seeing more cases in the children older than 5 years, because most of them haven't been exposed. We have managed to bring down those under 5. So relatively, we are seeing that remaining more in the children above 5, between the 5 and then the 15s.
I see.
Yes, so, and it's a general thing. As you begin to reduce malaria in a country, you realize that the picture shifts, where the children under 5 are not getting malaria. They have all the interventions to protect themselves. And then when
what interventions?
So we currently have a number of interventions to prevent them from getting, from the one that tackles the mosquito, and then the other that tackles the parasite. When it comes to the interventions that tackles the mosquito, we have the indoor residual spraying, where the houses of the walls are sprayed inside where we sleep. Generally, the mosquitoes that transmit malaria is known to feed indoors. When they feed, they must rest for the blood to digest. So they like to rest on the walls indoors. So we have this intervention of the indoor residual spraying that we spray the walls. Once they rest on it, they imbibe the insecticide and eventually they die.
But this is after they've bitten you.
That means they can't go and bite somebody else. So it's a way of reducing their life cycle. They die earlier than they can. And even if they bit you and you had the parasite and they picked, they can't go and give to somebody else.
So this indoor residual spray, is it the one that we buy on the market?
No. So this is actually done by people who are technically trained. Currently, it is happening through the public in Upper West, parts of Upper East, Northern region, and parts of Savannah, and in 2 districts in Ashanti. So we selected the regions or the districts that had the highest malaria burden, because it's expensive, we can't do everywhere, so we prioritize. And we started with that. We've done that in Upper West for, I think, about 10 years now. And we've seen the drastic reduction in our current parasite prevalence. Upper West, which used to be the region with the highest malaria burden, hasn't got that now. But that's just one intervention. And we are trying to get the private sector to help so that people who want to have it in their homes can call for it, pay for it, and have it done in any part of Greater Accra.
But it will not be available to the public to buy and use.
No, you can't. It's not the best thing to do it yourself, because you need to be properly trained to spray the walls and not leave any gap where the mosquito can still identify and go and rest and not.
And when you spray, how long does this spray last?
So the current one we use, we spray once a year.
That's great.
Yes. The insecticide lasts between 6 months to 9 months, depending on which insecticide you are using. And we do it just before the rainy season when the mosquitoes are going to increase, and then it protects them for the whole year.
And I'm guessing you must not paint your walls after.
Exactly.
So you must leave it there.
You must leave it after.
All right.
Yes.
Now, you mentioned earlier that we still have cases of people dying from malaria. Aside malaria prevention, I know we've come a very long way with our malaria treatment. How is it that we still have people dying from malaria?
So what we've seen is, one, people delay before they get the right treatment. So we have people who, malaria sometimes we think is an everyday disease. So they go to the pharmacy.
Over-the-counter drug.
Yes, and it's good. Malaria medications as an over-the-counter drug, because we want to make it available to everybody.
Yeah.
You go to the pharmacy, are given the medication. It's so effective that sometimes people don't finish their medication. They take day 1, they start feeling well, day 2, and then they forget. Then the malaria is not completely treated. And it's like, oh, I'm better, I'm getting better, then the parasite is still lingering in the blood till a point where it becomes very severe, and then they go to the hospital. Sometimes it's either too late, sometimes there are other comorbidities. So the other things come into play. Remember, I think the COVID example is much easier for people to appreciate. When we had COVID, we said those who have comorbidities like hypertension and diabetes are more
underlying
at risk,
conditions.
yes, of getting the severe forms. Sometimes people are really at a borderline when it comes to their blood levels. Malaria parasites break down your blood cells. So it tips them into anemia quickly. But anemia is one of the reasons why the children under 5 who have malaria die quickly. So these, some of these things make them die. Sometimes the right medication may not be started on time in a few times. And sometimes you are treating malaria, but you need to take care of the other things that has occurred because it's now severe. Looking at, let me try and use the word that's everybody. So we have in our blood, for example, we have liquids and we have minerals in it. So you need to make sure that all these, when we say the electrolytes, all these ones are well balanced, replace them. And unfortunately, some people do pass away despite trying to manage all these. But it is coming down. Last year, we recorded 151 deaths in our health facilities.
151 deaths from malaria?
From malaria. And that is a great improvement over the years. If you look at the past, even with fewer health facilities, we're recording in the thousands. Now we are recording in the hundreds. So
it still sounds like a lot to me.
It is a lot.
But it's not compared to the figure you just mentioned from previous years.
Even one death is a lot.
Yeah.
So we still want to be able to work to reduce people who die from malaria.
Are there different types of malaria?
There are. So generally, the malaria is caused by the parasite Plasmodium. But in that group, there are different subsets. So we have the Plasmodium falciparum, we have the Plasmodium vivax, ovale, and Malaria. There is some slight differences in the way they act or they behave. The falciparum is the most deadly. Is the one that is likely to make you more ill. And unfortunately for us, that's what we have here in abundance. We have the other one, the ovale and the malaria, which is not as virulent, but as severe as the falciparum, but we are seeing it in just about 5% of our cases. The vivax, but the thing about the ovale is that it can go and hide in your liver. So when we detect that you have ovale, apart from treating the parasite in your blood, we have to treat the parasite in your liver.
And you can find out this from just a simple malaria test?
Yes. So for us to differentiate the species, we need to use a microscope.
Do you do that when we test for malaria?
Yes, yes.
Okay.
By and large, we use the RDTs because it's not everywhere that we have the expertise and the logistics to use the microscope. But if, for example, you have, even if you are in an area where mostly we use the RDTs, and you have malaria and you are treated, and you keep coming back with malaria and it's still positive, it's a must that we look into your blood to see which type of malaria you have. Because, like I said, the ovale will hide in your liver and come back. So it can even hide in your liver for years. It goes dormant and then it just comes back after some time. So we need to add another medicine to clear it from your liver. Otherwise, it will come back. We don't have the fourth one, which is the Vivax in yet. We haven't detected it in us because it's more in the Asian regions.
Asia?
Yes, it uses a particular receptor in moving around your body, and we haven't seen that in blacks. But in these days where we are intermarrying and giving birth to children who are mixed race, we are looking to see if we'll find it in Ghana.
Now, we know that there were a lot of educational drives about malaria in the past, using treated mosquito nets, you know, not sleeping with your windows and so open, using the nets in our windows and so on. There was a time where we had a lot of it. The civic education was very widespread, but we don't really hear about it anymore. And I guess that's what gives the impression that malaria is no longer a problem. What are some of the things that we need to know in malaria prevention that we can do at home or day to day?
So, yes, we used to do, and we still continue to do, but not on that scale because you need to prioritize your resources. One of the things I'd like to start with is we understanding that the malaria mosquito breeds in waters that are relatively clean. So waters that gather, you know, when you go to some areas, when they bath, there's a collection of water behind the bathroom. We have areas around our houses that collect water when it rains. That is where the mosquito breeds. So if we are able to work to reduce such breeding sites, it means we are going to reduce the number of mosquitoes that will be developed to transmit malaria. The other thing we would want to add is that there are several interventions to prevent us from getting malaria. No matter where you live in Ghana, at least make sure you are doing one to protect yourself. From the indoor residual spraying to the use of the mosquito nets to making sure that you don't have breeding sites around your homes. We've even introduced larval source management where we kill the baby mosquitoes in the collection of the pool. So that we do. You may not do it as an individual.
I don't know why saying killing baby mosquitoes made me sad.
It shouldn't make you sad.
I guess it shouldn't.
Because of the word baby. I had to use it for people to appreciate. Yes, because we don't want them to grow to become old. And it's the old, actually, the females, you know, which bite. It doesn't mean females are
bad. Yes.
For them, it's a survival mechanism. They need that to fertilize their eggs. So that's how come the females do the biting for the eggs, yes. So, and the other preventive interventions for pregnant women, where you are given a medication when you become pregnant and you take it once a month till, it's usually after 16 weeks or let's say 3 months after you become pregnant, and you take it till you deliver. So we encourage our pregnant women to visit the antenatal clinics because they are there available free. If you happen to be in an area where we are doing the indoor residual spraying, please encourage the people to come. So there is one of the challenges we face is that when we are come to do indoor residual spraying in your house, we would have to work with you, because you need to move your belongings away from the wall. Then we can spray the whole wall.
Okay.
And sometimes because of that, people...
Is it injurious to your health?
No.
So if you ingest it, if you happen to touch the wall and eat,
no,
it's not harmful?
No, it's not
at
harmful.
all.
Not at that dose.
All right.
The reason why you can't do it on your own is that the person spraying, because you are so exposed to it, need to be properly gowned, properly dressed. No, we even wear mask, a particular kind of mask, so that the person doing it is not so exposed. Usually when we spray, we ask you to stay out of your home, sometimes for about 4 hours, 2 to 4 hours, depending on the kind of insecticide it is. Then it is safe to come in.
All right.
And you wouldn't have a problem.
Okay. So we should continue to buy the treated mosquito nets, which I think are available in most pharmacies.
Yes,
it's free in some health facilities as well.
Yes.
So treated mosquito nets. Try not to keep stagnant water, you know. There used to be a song, Malaria, Free Future.
Everybody knows
I love that
song.
Because it's very educative. You know, it tells exactly the things you need to do, especially to children, to fight malaria. Children who play with these Concos, and then nowadays they're all on their tablets anyway. But but you know, we used to play with these
exactly
empty tinned tomatoes and so on, milk tins, and then when it rains they collect water, and then they're out there, and then you know they breed mosquitoes. And so we're using our treated mosquito nets. We're making sure we don't keep stagnant water, and in areas where you have the spray available, allow people the people undertaking the exercise to come into your home to spray.
Yes.
These are the 3 key ways.
Yes. I one last one. In 7 regions in our country, in fact 2 more, in 7 regions in our country, we do what we call seasonal malaria chemo prevention.
Chemo prevention?
Yes. So we are giving medicines. Once it's chemo, it means it's medicine, to children under 5. They take these medicines during the rainy season where malaria transmission is very high. So it's once a month for 5 months, usually from June to about October.
Why don't we have a vaccine?
We do. So that was the last one. I said 2 more. You know.
Okay.
Yes. So we have a vaccine. If you remember, Ghana was one of the 3 countries that tried the vaccine.
Yes.
We piloted it, and we are expanding. Currently, the vaccine is being given to children under 2 years as part of routine immunization.
Okay, so now we are administering it.
Yes, in 91 districts.
I see.
Yes.
So if you go for normal weighing,
exactly,
your child will be given a malaria vaccine.
Yes.
In addition to the other childhood killer diseases.
Exactly.
And so there is actually the hope for a malaria-free future.
Absolutely.
And once you take the vaccine, it's for life?
No. So currently, my work would be much easier if it's for life. You know, it is not. So the vaccine, if you look at the time that the vaccine was tried and we piloted it, we've not yet had somebody go through for life. So currently we've seen an improvement or the reduction in the cases in children under 5 when you use the malaria vaccine. So we still say that it protects the child under 5. It's not a whole life's protection. Maybe we'll get there one day. You know, once it's always difficult to start something. Once you start, you look at ways of improving what you have done.
All right. So I guess the onus lies on us to actively do the preventive things that you have outlined.
Absolutely.
So that we can keep and remain safe.
Yes.
Is there anything else we need to know before we say goodbye?
So I think I will want to add, we just launched our malaria elimination plan, and our aim is to be able to eliminate malaria stepwise from the very low areas to the high areas. We will be introducing some additional interventions after we pilot, especially in Greater Accra. So we'll be working with you, we'll be working with everybody to make sure that gradually we get there. I think malaria is so much of a menace that we all don't want it to be affecting us. So it's a collective work. It's not the work of the Ministry of Health or the Ghana Health Service or the National Malaria Elimination Program ourselves. It has to be done by myself, you, and everybody out there.
All right. Thank you so much, Dr. Kezia Maum. We look forward to hearing more about what you're doing. And thank you for the good work you're already doing in malaria elimination and prevention. I didn't mention, but I see the advocacy in hospitals. Every time I go to government hospitals, at least when you go to the maternity side, you have people talking to pregnant women and their families and children about malaria prevention and the need for the treated mosquito nets. So thank you for your good work.
Thank you.
And we'll continue to follow the conversation.
Thank you.
All right. So there you have it. Malaria is still a problem in Ghana, and it is our responsibility to take charge of prevention and elimination of malaria.